Now we are live.
Yeah, now you're live.
So, hello everyone. I welcome all of you to this unique cancer care, understanding unique cancer care, especially the genomics aspect of it. It's a live show by Fortis Healthcare. And in this moderation, we have eminent panelists from across Fortis Institutes of India. We have Dr. Amit Bhargav, who is Senior Director of Fortis Vasant Kunj Medical Oncology. We have Dr. Sohail Qureshi, who is Additional Director and Unit Head in Medical Oncology in Fortis Shalimar Bagh. We have Dr. Vineet Govinda Gupta, who is Additional Director and Unit Head in Medical Oncology, Fortis Shalimar Bagh. And we have Dr. Uma Nangi, who is Senior Consultant for Medical Oncology from Fortis Mumbai. And today we are going to talk about something very, very pertinent and the newest kid on the block in oncology, which is genomics. And I am Dr. Shrinidhi Nathany. I am consultant molecular oncology and hematology from Fortis Gurugram. And talking about this is something very, very close to my heart because this is what I do and this is my bread and butter. So, what is genomics? What is genetics? And what role does it have in cancer care today? I would tell you is that once a cancer is formed, it is formed because there is a damage in the DNA which is causing the cells to grow uncontrollably. This damage can be inherited, it can be acquired because of the lifestyle choices we make, as well as in constant environmental insults which we are under, like UV radiation and tobacco and pesticides. But what is interesting is that there is a way to modulate these genes if we detect it early, if we detect it right by the right test. And then we have the new buzzword that is unique cancer care, that is precision, personalized, tailor made medicine, which targets the genes in the tumor which the patient has. And that is what the medical oncologists and the oncologists try and do, match the right drug to the right patient at the right time with the right dose. And this is how they help us to get good results, which has been shown in clinical trials also. So my first question would be to Dr. Vineet that how do you think that this genomic testing differs from traditional cancer diagnostics, which we have? Like, everyone says that the buzzword and the only word in oncology is biopsy, biopsy, biopsy. So how does this change?
Yeah, so I think you covered it quite well in your introduction. So see, the thing is that it's just a matter of limitation of technology. So biopsy has been there for hundreds of years. The idea was that if somebody has a cancer, you can take a sample of that cancer and look at it and check what kind of cancer it is and treat it. So if you go back many hundred of years, probably every cancer was treated the same way. Then people realize that when you take a piece of that cancer and look at it under a microscope, some cancer look like one thing, some cancer look like the other thing. So maybe if we treat different cancer in different way, you will get better results. So and when they tested it in labs, they saw that yes, that is actually true, that when you treat cancer which look like one thing and look like the other thing in different ways, you will get better result. So what happened later is that we had the development with technology, that we were able to look at the cancer at an even deeper level, not just key how the cell looks, but just at the genetic level. What are the switches which are on, switches which are off? What are the gene pathways which are activated? What makes the cell behave the way it is behaving? And now the idea is that why don't we treat the cell in the way each cell with a particular genetic switch can be treated in the exact way by which that genetic switch is damaged, and that is the idea behind precision oncology. So yeah, biopsy, the role still remains. So I know many people think that biopsy role will always remain, because how the cell looks is still important. But what will gain more and more importance is actually what is the genetic on and off switches inside the cell, which is making it behave in a certain way. And by doing this sequencing or genomic testing and other things, you can figure out what are the roots of that cell's behavior and get a better outcome by treating the cell in a specific way.
So thank you. That was bang on. So I'll just tell the people who are listening that first we always only took a piece of the tissue. Then we went one step ahead to look at whether your brown and my brown is different when we did IHC. And now we are looking at the genes in the tumor by taking out the DNA from that piece of the tissue and putting it to sophisticated genomic testing, the technique of which is right now beyond the scope of this particular panel discussion. My next question is to Dr. Amit Bhargav, sir. That do you think would you select specific type of cancers for these genomic testing? Do you think only specific type of cancers are beneficial if they undergo genomic testing, or everything it's a blanket thing?
See, uh, we have done sequencing for a lot of tumors, but if you look at the data, the maximum data coming in for sequencing and the genomics is lung, breast, colon, ovarian, endometrial, all these things, melanoma that we have done. But looking at sequencing and with my experience, what we have seen, I'll tell you a small story. This happened in 2014 with me. I had a young patient with CA stomach. It was adeno-CA, which was IHC proven, and we gave him two frontline lines of chemotherapy, which he failed. Then we reviewed the biopsy block. I had sent it for IHC, and in IHC I had also mentioned about c-KIT mutation, and to my surprise, that tumor came out to be c-KIT positive, and I was not aware that we had published literature on adeno-CA with c-KIT positivity at that time in 2014. And I discussed with Dr. Anita Borges. She said, "You please give imatinib, and the patient should have a response." And she was absolutely correct. And we gave imatinib. He did not respond to chemotherapy, but imatinib, he had almost 70 to 80% response within 3 to 4 months period. Though it couldn't be curable because it was quite an advanced disease, but that was something which opened our eyes that genomics is something that we need to do. And so what I feel that the role of genomics is for where we order tumor, where you have a poor prognostic tumors at the outside, like pancreatic, gallbladder, uh, liver, advanced malignancies, where you have very limited drug options available with you. You can get some answers through them. The other tumors where I would order for sequencing is frontline failures. Failures like front line chemotherapy failures in breast, lung, colon, stomach, melanomas, all these things I would order. And now there are certain tumors like lung, I would definitely go in for an upfront sequencing because we have too much data on lung and breast and ovarian. So these are something where we have young patients who have advanced disease, and cost definitely is an issue, but I would definitely order them. It's all patient's choice, but these are something where I'd order sequencing at the front line.
So, in a nutshell, if I summarize, it means that all common tumors we should definitely sequence, like lung, colon, and all uncommon tumors also you should sequence, just for the chance that you may find a needle in the haystack, and the patient might just benefit. So, as a genomics expert in my field, I would say just sequence all tumors, because it is just good to know the biology, generate your own Indian data to understand what is the Indian makeup, because I'm sure we are different from the West as well. And, considering the limited amount of drugs which we have available in India, I think we should sequence, just so that in case if we find, the patient might just benefit, right?
True, and certain tumors where we have a upfront a good PFS or an overall survival, I would prevent those tumors, like a breast with T1, T2 lesions and ERPR positive, breast, a lung which is operable, and have a good PFS and OS. I would preferably reserve those tumors for upfront sequencing. Maybe sequence them at the front first line failure.
So my next question would be to Dr. Uma, that based on a genomic result, how would you decide that you would give a targeted therapy, or you would give immunotherapy, or you would use the main weapon of mass destruction, chemotherapy?
Sorry, you can. Okay, can you hear me? Yeah. So yeah, it is a very, like, last decade or so has seen really a big leap in oncology in terms of the molecular the molecular basis of oncology actually. And understanding this genomic profiling has made us sort of improve our knowledge about the drivers of oncogenesis. So we do know that there are certain mutations which keep occurring in our cells, but not all of them lead to tumors, not all of them are responsible to cause any disease. But we are with this newer technology, I would say, NGS and whole exome and whatnot, better, Shrinidhi. So there we are trying to decipher and try to analyze each and every molecule and figure out what is driving the tumor or what is the basis of oncogenesis. And that is something which has not only it has helped us define the targets for treatment, so that I am better able to give this particular drug to a particular mutation. And not only that, it also helps me identify patients where a particular drug may not be really effective. So suppose if some mutation is there, I know this is the drug which is probably not going to work, or if it is absent, I know this is not going to work. So both ways it helps me decide what kind of treatment to give by doing a genetic analysis. Now mainly, obviously, we do this for advanced tumors like we discussed, but certainly in certain early tumors also we are now looking at it, like lung, breast, etc. We are trying to give targeted drugs even in early stages.
Dr. Sohail, can you, I'll extend that question. So, can you tell me how do you tailor what is, just for the benefit of the viewers who are watching, what is targeted therapy and what is immunotherapy, and how is it different from what we already do, and why is genomics important in targeted therapy and immunotherapy?
Okay, thank you, Dr. Shrinidhi, and hello to my fellow panelists. And I think that's a very pertinent question with the way we treat cancers in the 21st century. So, if I were to take your thoughts back to maybe 50 years, then traditionally in our society, we used to have astrology based predictions, and people used to go for hand reading to know their future. In the Western society, there used to be crystal ball gazing, just to know. People were interested to know what can happen to me in the future. It is actually something that we are doing today by peeping into the DNA and the RNA composition of tumors, and to understand better how these tumors can be treated. So we are not just reading hands of patients anymore. हम हाथ नहीं देख रहे हैं. We are actually looking into the tumor genetics, and we are trying to find out genetic mutations and genetic targets in the DNA and the RNA of the tumor, which helps us to detect targets which can be specifically employed for targeting that particular tumor in a more unique way and in a more targeted manner, so as to avoid the damage and toxicity to the other cells of the body. That, in a nutshell, is targeted therapy. For example, in metastatic lung carcinoma, as Dr. Amit sir, Bhargav sir also already pointed out, that we have a wide array of targets available now for which oral tablets are available, and they have actually transformed the care of lung cancer from what we used to say, that the average survival of stage 4 lung cancer 20 years or 25 years back was 6 to 9 months. Today, we have patients who are living with stage 4 cancer with targeted therapy for years altogether, not just an improved quality of life, but also a quantity of life, and they are away from the effects of chemotherapy. So today, as you said, we are talking about genomics. As we are moving forward, we are going to be talking about proteomics, because we all are nothing but an expression of our protein level at the molecular level. So genes end up making proteins, and these proteins eventually decide who we really are, what our tastes are, what are the propensities for us to develop a particular kind of illness in the future. And then there is a field further down the line, which is fragmentomics, where you are going to study the fragments of the tumor shed into the blood. And that brings me to something that you specialize in, and which is liquid biopsy, that is transforming the care of cancer patients, where, as Dr. Vineet also said, that we may not even like do a biopsy if we are able to ascertain from the blood itself whether we are able to find targets that can better treat these patients. Immunotherapy is also a step in the same direction, wherein we utilize body's own immune cells to target the cancer, because this works on the simple premise that our immunity has kind of forgotten to fight the tumor, and that allows the tumor to grow. These immunotherapy drugs go inside the body and they reawaken our T cells, the T lymphocytes of our body, to understand that these tumors are actually detrimental to them and start fighting them all over again, which they have not been doing for those period preceding that. So immunotherapy employs your body's own immune cells to fight against the cancer and makes the treatment more effective and more acceptable to the patient and less toxic.
Right. So if I summarize it in lay language, if I am locked inside a room and if I have to get out of the room, then if I bang open the door, then it is weapon of mass destruction chemotherapy because I don't know the genomics. If I have the key to the room, that is targeted therapy because I know what is the genetic tumor and I'm targeting it with that drug. And if I get inside the room from a backside window, then it is immunotherapy because I'm trying to play around with the body cells to kill the cancer cells. Is that right?
That's correct. That's a very nice analogy. I'll use it in my next patient. Although I'm not sure if the patient would like to enter through the back window.
So, okay, so getting back to my discussion. So, Dr. Vineet, do you think genomics, doing a tumor genomics today, when the patient just walked inside your uh, OPD and you have diagnosed that the patient has cancer, do you think today the genomic profile, what you get, the gene information, whatever you get, is going to help you predict a risk of recurrence of that malignancy in that particular patient?
Yeah, so see, definitely. So, like it has already been discussed. Okay, see, the more information you have, the better it is. Okay, so the problem is that, see, they are all pieces of a puzzle. The kind of stage, what you see in the PET scan, what the patient looks like, what the blood test, what is the biopsy ki immunohistochemistry mein kya hai, and what are the genetics of the tumor. They are all different part of the same puzzle. Okay, so ultimately the puzzle, when you put all this part together, that will what will decide the patient's survival or outcome or recurrence. So the more information you have, the better you can solve this puzzle. So there was a discussion whether we should do genetic testing for everybody. I think it is just a matter of cost. I think that is the only reason. So see, it is not going to harm the patient to have more information. If we have more information on how the tumor is going to behave, it is definitely not going to cause any harm to the patient. And now recently, I have seen some studies coming up where it is very, very clear that even in an early stage patient, suppose somebody is stage 2, stage 3, if you have the genetic information, you can give them something to improve their survival. So it's not a must that only in advanced stage patient you have to do all this. And the cost of these technology are decreasing every year. So there is something called inverse Moore law for gene sequencing, which says that the cost will become half every 2 3 years. So the cost is going to decrease very, very exponentially. And good, I think patient where cost is not such a big issue, they should get it done because it will definitely guide their management. It will definitely help in improving their outcome, choosing therapies. Maybe not immediately, but maybe sometime in their treatment journey. And maybe not for every patient, but over time, the number of patients who will benefit will keep increasing. So that is the importance of the coordination between the evolving field of molecular oncology and the old field of medical oncology, that you need to judge the risk benefit of each intervention. So definitely there is a cost attached to these things, but the cost is going down and the benefit is increasing. So over time, I think it will become more and more popular to do these things in every patient when they walk in.
So I'll extend that question related to cost and accessibility to Dr. Uma, that what is your take for the benefit, that how affordable or how accessible is it? Like, we all work in metro cities and we all have patients coming from metro cities, but what about the rest of India, where how affordable or how accessible is this, and should there be a legislation for the same?
So it's a very good question, actually. I think definitely, like Dr. Vineet pointed out, that the accessibility has improved over the past few years. Like probably, like a decade ago or so, we would have hardly been doing these tests, mainly for the simple reason that they were not even done in India. There were very few labs who were doing it, and we had to send the samples outside, and the reports used to take so long to come. Now, obviously, with so many labs, so many Indian labs which are already doing it, and like Dr. Vineet said, the cost is starting to come down. definitely the accessibility has improved. Yes, predominantly in the metro cities where everything is there, but in even in many of these labs, they also have, people do come home and collect the samples if you give the number, etc. So a lot of times the sample can be collected from home. It may take a little longer, but I think with the current scenario, I think it would be easier even in the smaller cities to do it. Yes, but if you look at rural India and other part of, obviously the accessibility there is going to be poor. But definitely I feel that overall, the cost as well as the access to this particular tests has improved in the last few years or so.
So this is just for the benefit of the viewers that a few years back, even a simple BRCA testing, that is the gene which is most commonly implicated in breast cancer, was over 1 lakh Indian currency, which is now even probably less than 10,000 rupees, available in many parts of the country. It is more accessible, and even the PM's initiative of Moonshot, I'm sure it is going to help in bringing down the cost. So, Dr. Amit Bhargav, sir, I would ask you that, how difficult is it to convince the patient to undergo a genomic testing, which actually brings me to the point that, what are your views that how can we increase more and more public awareness for increasing the uptake of genomic testing? Because anything genomic relates to genetic in India, and it is also associated with a certain social taboo. So how can we increase the public awareness?
See, what I have seen is, if you actually explain them in a very layman's language, and it all depends upon your skills, that how you explain it. But uh, to me, it seems very not very difficult to convince patients to go into genomics, because in my hospital, as the group of patients that I mentioned, we invariably go ahead with sequencing, and we do not have any panels, or we do not have any kind of PSUs here, where like CGHS, ECHS, where cost is not an issue. Our patients are mostly cash paying. So what I tell them is that, getting a good diagnostic workup on your cancer is very important, so that we can plan the treatment effectively, which can save your cost for treatment. Suppose I have a tumor, like we had in one of our ladies I presented in the molecular tumor board as well, where it was such a bad tumor, where she had all the resistant genes there, which was resistant to practically all kinds of chemotherapy. And so, and she failed two lines of chemo. So we did not go ahead with any kind of chemo, and we went ahead and did a palliative surgery for the breast. And trust me, after the surgery, there is no local recurrence, there is nothing, and she's doing very well. We gave radiation. So this is what is the effective planning of your further treatment can happen, if you know the biology of the tumor well. Because see, as a medical oncologist, for me to understand the behavior of the tumor is very important before I actually plan the treatment, so that I can tell the patient what is what will be the outcome, what is going to be the prognosis, what is going to be the response rates, and what will be his progression-free survival and overall survival. So all these answers, I can get through genomics.
um, so basically, it is easy to convince the kind of patients we encounter right now, but how do you think for the general public we can increase awareness? And do you think doing what we are doing today and more such activities and more outreach activities can increase public awareness?
Yeah, this is a gradual process, because if you look at the treatment profile or the paradigm the cancer has gone through in the past, even getting an FNAC was a difficult task around 30 years, 40 years back in our country. People still feel that, if you do a biopsy, the tumor will spread. So the same situation is happening with the genomics, because the understanding of genomics to the general public is very low. So this is a gradual process, and with these kind of programs, that what we are doing will definitely increase. And what we have done in the past is writing articles in newspapers, going on to the electronic media, putting the importance of these things on radios and televisions. So that is how is the way to go to increase the uh, awareness about genomics. And this is probably the same pattern that we had followed for treating cancer, because a lot of patients never used to come up for treatment for cancer also. But when we showed the results, when we came up that you do have a good quality of life and meaningful life post treatment of cancer, people have started coming in. I guess the same procedure would be true for genomics as well.
So, Dr. Sohail, I would, right now we all spoke about how genomics is helping us understand the biology, how it is helping us tailor the treatment for the patient and increase the response, and we even spoke about cost. But once you get a report, once you get a genomics report, do you think, spending time with the patient and making the patient understand the report is important? Do you think a post-test counseling, we always offer a pre-test counseling, but how important is a post-test counseling and, keeping the patient informed about tailoring the treatment based on that report? How important is that, and how much is it in your practice?
So that's a very pertinent question because just to put it in perspective, a patient, when he comes to us with a simple CBC report, they have 10 questions to us. Why is my MCV low? Why is the RDW high? Or for that matter, simply why this is given in bold, even though the hemoglobin may be 10.1, but just because the lab has made it bold, they would feel there's something wrong. So they would have to be, this is a time for hand holding and tell them that these are things that we expect on treatment, and it doesn't need to be, it's no cause for alarm. All the more the reason when we are trying to discuss genomic reporting with them, because not just the patient, Dr. Srinidhi, and we have discussed this time and again in molecular tumor boards, that even we as clinicians and oncologists sometimes need to spend time with each other and talk to our molecular geneticists and experts like you to understand the nuances of a report better, because we are all climbing that learning curve together. It's a relatively newer area of research and we all are learning together. So the patient would definitely have his own reservations and own concerns regarding understanding that report. If that report would make a treatment option open for a patient, then he would ask us about what are the success rates of that particular targeted therapy or for that particular treatment working on him. If it is approved by guidelines, or if it is a off-label use, then we need to tell them that this is something that has not been studied. So these are the matters that we all always discuss in a molecular tumor board, and we are all learning from each other's experience, and we all become wiser in retrospect. And I would say that as we go on and as genomics becomes the order of the day, I think we are going to become more and more adept at handling such situations. And but the patient would definitely require to be explained that report, to be told what really the options are opened up for him with that report, and how far we are going to be able to extend his life in a more meaningful manner with the treatments that report might offer. So more often than not, sometimes there are reports which give us the option of a drug, and that drug is not available in India or is too costly. And then you start talking about the procurement pathways of that drug. If it needs to be imported from somewhere else, it needs to be accessed through a compassionate access program if it is available in India, or if it is available in India, then what are the side effects one might expect with them? So these are the options that we often discuss with the patients, and sometimes it provides us great results. And I can just cite one example out of sheer memory. This patient presented to us with a metastatic lung cancer 3 years ago, 2021, 4 years ago. And we started her on chemotherapy. Both her lungs were completely riddled with cancer. She was a young mother of two kids, and we sent her biopsy for an NGS testing, and we were lucky to find a RET fusion in her tumor biopsy. Luckily for her, at that time, the compassionate access program of selpercatinib, which is a RET inhibitor, was available in India, and we got her enrolled in that particular trial. And it's been 4 years, and she's disease free. Now, how would one explain that maybe 25 years back? And the chances of someone having a RET fusion positive tumor is around 1%. and we are able to get that drug absolutely free of cost. It is still not available in India as of today, and she gets that completely free of cost. So these are the kind of situations that give us hope and that give us a lot of strength in the fact that if we are able to find something to that effect, it might just be a game changer.
So, we had a great discussion about what genomics can do, why we do, which cancers, how we inform treatment with genomics and genetic information, how cost effective it is becoming and accessible it is becoming. So, I'll ask all my panelists to give one line, one last genomic mantra, one liner. So, we'll start with Dr. Amit.
My mantra is that like this is like your Janam Patri. So genomics is the Janam Patri of the cancer.
Right. So, match your genome patri, I would say. Dr.
Yes.
Uma. Dr.
Dr.
Uma,
Uma,
you're
you
on.
need to unmute.
Sorry, sorry. So no, I'm saying that so this genomic profiling is the future of oncology. We all agree on that, I think, and it is soon. We are going to be writing prescription just looking at the DNA RNA of each tumor and then prescribing accordingly. So I think that's the future, and I think all the patients should be aware of all this, and try to and hopefully when the cost comes down, it will be more accessible to most of the patients.
Dr. Vineet.
Yeah, I think probably it is the most one of the most important innovations in cancer treatment, and it is an innovation, which innovates on itself. So over time, it's becoming more and more sophisticated, and I'm very sure in 10 years it will be the cornerstone of management. So right now, many people think it's a new thing. Okay, so see, what I feel is over the next 5 to 8 years, it will become very very cheap, very easily available, quick turnaround time. You will have the report in 5 days, and it will be the cornerstone. So when we write the diagnosis on top of the paper, the genomic report will be written next to it, and it will have to be written. Without that, you will not get good quality care. So for good quality care, you will need to have the genomics, and it's just a matter of 5 years. So we need early adopters should be adopting it as soon as possible, and it is going to be the future for sure.
So means genomics in action today is distraction for cancer tomorrow. So, Dr. Suhail.
So I think it has been summed up very nicely with all my fellow panelists and yourself. So just to put it in perspective, 25 years back, we were still writing letters. I remember when I was in first year, I was writing letters back home. I used to take that stamps from the post office and write letters back home. In the 25 years since, it's actually become obsolete. Nobody writes letters anymore. Nobody sends Archies of Hallmark birthday greetings anymore. You have those WhatsApp greetings, and the world has actually become shrunk in one palm of yours in your mobile phone. This is the potential of genomics in the future in oncology. If I were to draw the parallel between the changing technology in the past 25 years, and this is how rapidly the field is going to change. If we don't change ourselves and we don't adapt to the change, we are going to get left behind. So the mantra would be genomics is the future, learn, embrace, and lead.
Wow. So I think thank you so much to all my panelists, and we had a great discussion, and we even shared a little bit of anecdotes and jokes. And I hope the message that unique cancer care is unique because the genomics of every tumor is unique, every DNA is unique, and hence every tumor is unique. So I will conclude by saying that decode the tumor genomics and stay informed, stay ahead, stay healthy. Thank you so much, everyone.
Thank you.
Thank
Thank you,
you.
Srini.
Thank you.
Thank
Thank
you
you.
all.
Bye.
Thank you. Have a pleasant
Bye.
evening. Thank you. Thank you. Bye.